morning, good afternoon, good evening po sa lahat. Saan man panig po kayo ng daigdig naroon. Welcome to our 98th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being a part of our credible online community. And to all those who have just discovered us for today, welcome po. At sana po tuloy-tuloy na po ang inyong panonood at pagsubaybay sa ating mga webinars. Matapos po ang more than 2 taon po ng ating COVID-19 pandemic, there have been great strides sa ating pag-intindi or our scientific understanding of the virus, yung pong mga variants, including the vaccines, yung mga gamot. This paved the way po talaga para magkaroon po tayo ng strategy in terms of preventing ang ating mga infections and also ang ating mga antiviral drugs for early treatment. Ang goal po nito is to really decrease yung incidence of hospitalization from severe COVID and preventable deaths. And from the early days na meron pong iba't ibang mga balita na hindi po kumpirmado sa patungkol po sa mga gamit ng mga certain drugs on how to prevent COVID-19. Currently, the scientific community now comfortably is able to say that there are specific treatments for COVID-19 that can be used at home and in the hospital setting. So for today's webinar, we will be discussing some of the treatments that have been making recent headlines. Please pardon me if I pronounce it incorrectly. NIRMATRELVIR-RITONAVIR, MOLNUPIRAVIR, at REMDESIVIR. May mabisang gamot na po ba tayo laban sa COVID-19? I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of Philippines, Manila. Always a pleasure to be with all of you during our regular Friday launch date po, no? And I always very happy and pleased to share hosting duties with our adjunct research faculty, our beloved mentor, and the special envoy of the President for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie.
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat. Saan man kayo naroon? We hope you're all doing well. I was asking you in the chat kung mainit, kasi may news ako tungkol sa init. Merong mga lugar na super init. Anyway, thank you for being with us today. For those of you who are watching us on the playback or also on Facebook, we welcome you, and it's really great to be with you every Friday. We try to bring you the best speakers, and we do have 2 excellent speakers today, so stay with us. Now, we'd like to also acknowledge that we have a group that's watching from the Center of Kidney Diseases of the University of Santo Tomas Hospital. Mukhang yung mga patients habang nag-hemodialysis, naka-on itong Stop COVID Deaths. No? So binabati po natin ang ating mga pasyente na nag-hemodialysis, mga kaibigan po natin. Tsaka congratulations to the blessing and opening of the St. John Paul II building recently. So thank you for all our friends and yung mga nagda-dialysis. Relax lang kayo, no? Para I hope that this would be very interesting for you tsaka sa ating mga staff na nakikinig. Okay, so we are entering our 3rd year. At napansin niyo siguro dun sa opening, sabi natin, well, we said, should we change the title? Kasi parang minsan merong ibang issues na kailangan pag-usapan, no? So we said, let's keep the title to Stop COVID Deaths, but the C is current COVID infection. So hindi po natin bibitiwan yung COVID na yan kasi hindi pa po ito tapos. Hindi pa po ito tapos. No? I know a lot of people are feeling like, okay na, di ba? Parang ganun. But you know what? It's better to be on the safe side and always be updated because we don't know what's happening in other countries. And I think that's something that we want to bring to you, what's happening in other parts of the world, because we've really seen how in a short span of time, the whole world could be affected by a pandemic. Okay. Then we have O for other outbreaks. The other day we were talking about measles and, we're a little bit concerned about that. Other viruses, infections, and disasters. So C for current COVID infection problems, O for other outbreaks, V for viruses, I for infections, and D for disasters. I think we can expand our platform a little bit, but we are not dropping the discussions on COVID, Raymond. No? Parang,
Or the title, Dr. Susie.
Or the title, we're keeping the title. So we're still Stop COVID Deaths, pero wag kayong magugulat kung paminsan-minsan meron tayong ibang mga topic that are relevant also for you as frontliners. Now, we also have introduced a new News section. Okay, TVUP. Okay, in our news for today, UNICEF and WHO warn of a perfect storm of conditions for measles outbreaks affecting children. An increase in measles cases in January and February 2022 is a worrying sign of a heightened risk for the spread of vaccine-preventable diseases that could trigger larger outbreaks, particularly of measles affecting children in 2022, warned WHO and UNICEF. Pandemic-related disruptions, increasing inequalities in access to vaccines, and the diversion of resources from routine immunization are leaving too many children without protection against measles and other vaccine-preventable diseases. So last time we talked about measles, and we are really deeply concerned about the very low vaccination coverage for measles. What we don't need is another outbreak, and what we don't need is a measles outbreak, because we saw last week how severe the complications of measles can be. Okay, in related news, or another set of news, heat wave in India leaves millions struggling to cope, according to the British Broadcasting Corporation. So the India Weather Department has issued a severe heat wave warning as temperatures soar, throwing millions of lives and livelihoods out of gear. Temperatures are rising rapidly in the country and rising much earlier than usual, according to their prime minister. The India Meteorological Department forecasted a gradual rise in maximum temperatures by 2 to 4 degrees, with no change in the weather thereafter. And there is also news coming out of Pakistan that in the city of Turbat, because of disruptions, they have had massive energy shortages. So aside from the heat, which is going as high as 50 degrees centigrade, air conditioners and refrigerators cannot function. And one person has described it as living in hell. So I was asking you earlier in the chat kung mainit sa inyo, no? And I think we have to be very aware of the possible impacts of climate change on all of us, because there are really severe health outcomes. No, so one of my friends in India just told me that temperature was 53 degrees, and my friend went swimming, thinking na okay lang, no, to swim kasi it'll be cool, no. But even with that, even after swimming, he noticed he was not perspiring. And he was very, very tired. So it starts with heat exhaustion. But when you don't perspire, that means the ability of your body to regulate your temperature is compromised. And that's what will cause a heat stroke. So simple tips, right? Keep hydrated, stay out of the sun pag masyadong mainit. Drink a lot of water, take a bath a lot, right? Bring a wet washcloth, especially elections are coming, people might have to line up, baka mainit masyado, magdala kayo ng tubig, no? Hydration, of course, and wear light clothing, yung mga damit na na hindi dark colors, and be as cool as possible, because taksil itong init, no? And so anyway, so that's our news for today. Raymond, over to you.
Thank you, Dr. Susie. At please put in the chat po, no? Or dun sa comment section if you enjoy ang ating very, very new segment wherein we deliver a bit of the recent news. And if there's anything that you will want us to focus on, we'll be more than happy to oblige as soon as we're able to get more information from recent news outlets po. No? For today's webinar, we will be discussing the recent strong recommendation, in this as recent as April 22nd po, no? Which was 2 weeks ago by the World Health Organization for NIRMATRELVIR and ritonavir. Ito po yung sold under the brand name Paxlovid. Alam ko po, narinig nyo na po ito for mild and moderate COVID-19 patients, especially those that are at the highest risk of hospital admission. It has been called as the best therapeutic choice for high-risk patients. But However, hindi po lahat ng bansa is able to avail of those drugs. Even in the Philippines, very, very few hospitals are able to get Paxlovid. In the Philippines, as you might know, marami po tayong mga referral hospitals. It would ideally be good if all of our COVID-19 referral hospitals would have this best therapeutic choice, kumbaga. We have invited two experts, one based in the US and one based in the Philippine General Hospital, to be able to discuss medicines, other medicines, bukod po sa Paxlovid, for all of our inpatient and outpatient care. But to set up
Yeah.
our discussion po into context, please watch
Teka,
this.
Teka muna, Raymond, bago ko mag-introduce ng ano, may dadagdag lang ako.
No
Sorry.
problem, no problem.
May dadagdag lang ako kasi there were some people who are asking me, why are you talking about treatment? I said, because nobody's talking about it. No, parang this is really good news for all of us. Na pag nag-test positive kayo, pwede kayong uminom ng gamot para hindi kayo ma-hospitalize or hindi magiging severe. Is it 100%? No, but I think as the pandemic has progressed, so in the beginning we didn't know how to manage in the hospital, di ba? Tapos there was no vaccine. Ngayon, we improved in terms of management in the hospital, and PGH really did a lot in that area, no, leading the dissemination of information of how to manage in the hospital. And we're going to hear more about what's the latest in hospital management. But then we shifted to vaccination, which is great because it's preventive. But as we mentioned earlier, hindi pa po tapos ito. Baka mag-test kayo ng positive sa COVID. We want you to know that there are medications that are available. Okay? Now, it's more available in some countries than others. That's why WHO has said, kailangan palaganap natin yung gamot. Kasi para ma-avoid natin yung unnecessary hospitalization and death. So anyway, I just wanted to add that angle a little bit, Raymond, kasi I don't know that we're talking about it that much in the Philippines. Mukhang hindi, no? So kailangan alam natin yan na pag nag-test kayo ng positive, pwede kayong uminom ng gamot sa bahay. Okay? At hindi ito yung mga gamot na dating pinag-uusapan natin. We'll take that up later. Okay, go ahead, Raymond.
The other thing, Dr. Susie, is that WHO usually, well, you all know this, the WHO takes a long time vetting all of this. So for them to be able to arrive at a strong recommendation at this point in time, that's a milestone in and of itself, and that's why we're highlighting it for this webinar po.
Agree, Raymond. Agree. Tama ka dyan. Tumpak, partner. Tumpak.
So we'll be segueing po to this very, very short video that's produced by TVUP. The question that we posed to a person on the street, sa palagay po ba ninyo, may gamot na po ba na epektibong panlaban sa COVID-19? May nabalitaan na po ba kayo na may mga gamot laban sa COVID-19 na maaaring ibigay sa bahay, especially kung magka-surge po ulit? Please watch this.
Sa palagay ko, wala pa. Kasi sa mga nababalitaan ko naman na wala pa masyado. Although dati may mga naririnig ako. Kaya lang mga hindi pa siya naaral maigi. So palagay ko wala pa.
May nabasa ako na parang may isang COVID pill na pwedeng parang gamot siya against COVID. Hindi lang ako sigurado kung meron na ba siya dito sa Pilipinas. Hindi ko maalala yung specific brand name ng COVID pill na yun. Pero para siyang nasa blister pack na parang gamot talaga.
Mga nagkaroon ng COVID na mga pasyente, usually yung mga naka-quarantine noon, may binibigay naman po silang mga gamot nga lang, mga paracetamol lang, then vitamins.
Sa palagay ko po, sa ngayon, wala pa. As in, bakuna lang talaga po yung the best option para maiwasan yung COVID-19.
Molnupiravir ba yun? Basta hindi ko sure kung yun talaga. Pero basta may mga gamot ako na naririnig na binibigay daw nila. Kung proven siya talaga, susuportahan ko yun. Kasi syempre, nag-effort sila na aralin yun and na-prove naman nila na effective. So, suportahan natin. Katulad ng vaccine na yun. Syempre, hindi naman sila talaga gagawa ng makakasama sa atin eh.
Kung may clearance siya sa FDA, sa, ano bang tawag doon, yung Philippines FDA, kung safe naman siyang, kung may FDA approval, siguro i-recommend ko yun.
Actually po, meron akong kapatid na nagkaroon ng COVID. Ngayon, nung dinala namin sa hospital, merong nireseta sa akin may nireseta sa kanya pala yung doktor niya. Yun nga po, medyo sobrang mahal siya, kaya hindi din namin nabili yon dahil parang almost 600 to 800 yung isang peraso. Bibilhin mo kasi kumbaga buhay yung hinahabol mo, 'di ba? So sa time na yon, kumbaga sobrang nakakakaba, nakakatakot. So kung may pera lang, kayang bilhin, pwede. Kaso lang nung time na yon din, isa pa, hindi mo siya mahanap sa mga butika, wala nga po sa mga butika Kumbaga, sa isang hospital doon, sa pharmacy lang nila pwedeng mabili yung gamot na yon kasi parang bago lang inilabas.
Mag-ingat pa rin syempre, tsaka sumunod dun sa mga measurements na binibigay ng gobyerno sa atin, and yun, wag tayo mag-relax para at least kahit paano, tayo na lang mismo yung tumulong sa sarili natin para makaiwas tayo sa surge.
Thank you very much, TVUP. Always great to hear from persons on the street. No, parang mga ordinary citizens, what they know, what they're thinking, and also for us as frontline workers, for you as frontline workers, no, makikita nyo kung nasaan ang mga pasyente natin in terms of their understanding para makatulong din kayo to give them the latest information. Raymond, over to you.
Thank you, Dr. Susie. For those who are asking, lalo na po yung sa mga may-message sa Messenger at nag-email po, certificates of attendance will be given to those who watch at least 50% of the webinar duration. Hindi po kami nagkakapagbigay pa po ng certificate ora-orada pagkatapos po ng webinar. It usually extends throughout the week, but so far we have already sent out certificates of attendance for all webinars from 1 to 96. There are still those na medyo struggling lang po in terms of being able to send out for webinar 97. If you have not received and you feel that you should have received it, please email us at stopcoviddeaths@up.edu.ph, especially if it falls between webinar 1 to webinar number 96. For today's webinar, we will be having a standard panel discussion format wherein we will having a talk from our experts, and then followed by a Q&A session. We will be entertaining questions coming in from the Zoom and also those who are watching us in the Facebook and YouTube channels. And finally, our webinar po is able to accommodate up to a maximum of 3,000 participants dito po sa Zoom. So we hope that everyone who are still trying to get in sa Zoom po, no? Kasi we are seeing we have more than 1,200 I think registrants, but we are only seeing 540 participants po dito po sa Zoom. So hopefully you'll be able to join us. If you're joining us po via YouTube or Facebook, we hope you'll be able to engage pa rin sa ating community by typing in sa comment section, and those who are putting in your inputs or anything po sa chat box that may be interesting, we'll be sure to keep an eye out for that. Dr. Susie?
Okay, so I think we're going to talk today about treatment, so that you'll all be updated. We will also be updated, no, from our specialists on the antivirals and how treatment plays a role in controlling the pandemic. As I said, hindi pa to tapos, no? So dapat tayo medyo we have a high index of suspicion, and we know all the tools that are available to the frontliners for individuals who get COVID. So over to you, Raymond. I think we're going into
We have our new segment again, pero very very cute lang po na intro. It's an animation of the fun quiz intro video.
Sige. Okay, go Raymond, go. Hello.
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Thank you so much, TVUP. Cute talaga yung mga animation natin. For those that are asking po, no, wala na po muna tayong Menti. We have shifted po to slido.com. So as mentioned po, if you open your browsers, type in www.slido.com. Especially for those who are outside of the Zoom, sa YouTube or Facebook. And then, once you go to Slido, enter the number po or code 549667. That's 549667 for you to be able to participate in our fun quiz. Ang questions po natin sa Zoom at sa Slido ay magkapareho lang po. And for today, we have 2 questions. First question reads, Paxlovid contains ritonavir, and ritonavir has multiple drug interactions, including with rifampin, phenytoin, and simvastatin. Ito po ba ay true o ito po ba ay false? So medyo madali lang po ang ating fun quiz for today as our participants.
Oh, hindi madali yan, Raymond, ha?
True or false?
Kailangan medyo alam natin yan. Oo. Biglang nag-doubt sila, nag-doubt sila. Mag-google nyo yan kung alam man ng Paxlovid, pero dapat alam natin to. We should know this. Go ahead.
So for those who are joining us po, locally, we'd like to greet those who are logged in from the Rural Health Unit in Cubungan, Benguet, from the San Antonio Life Care Hospital in San Pascual, Batangas, from Oriental Mindoro Provincial Hospital in Calapan, Western Visayas Medical Center in Iloilo, and the St. Elizabeth Hospital in General Santos City. Question number 2. It reads, what is considered standard of care of inpatient management of severe COVID-19? Is it corticosteroids? Is it hemoperfusion? Or is it pagbibigay po ng isa po sa mga drugs na pag-usapan natin, molnupiravir? So, we are seeing po a few of our participants. Padagdag po ng padagdag. Hopefully, there are those who are joining us internationally from Handa Medical Center in Battambang, Cambodia, Ministry of Health, Bandar Seri Begawan, Brunei, from the Raja Isteri Pengiran Anak Saleha Hospital in Bandar Seri Begawan, again in Brunei, Nguyen Thai Polyclinics in Vietnam, Bangkok, Thailand, from the Chonin Hospital in Taipei, Taiwan, the Prince Sultan Military College of Health Sciences in Dammam, as well as the University of Ha'il and Qasim University in Buraida, all in Saudi Arabia, Lunichi Ali University of Lida to Algeria, from San Diego and Burbank, California, also the Philippine Nurses Association from Edmonton, Alberta, Canada, and St. Eustatius in the Netherlands. So we will not be closing muna itong fun quiz. We want to be able to see ano po ang pipiliin po ninyo sa ating mga kasagutan as we move on to our webinar proper. Dr. Susie.
Okay, thank you very much, Raymond. So we have some technical questions there for you, pero we all want to walk away from the webinar saying na, we learned something and this is what we remember, okay? So we always want to bring you the best speakers, and we do have 2 of the best infectious disease speakers we have had on the webinar. And our first speaker, Suki na rin to, he's our go-to person. He's actually practicing in the United States. He's an infectious disease expert, and he always comes to our webinars with the latest research as of the last hour, and really has been very enlightening and a good guide for us knowing what's happening in other parts of the world. So we'd like to welcome Dr. Franco Felizarta, who's also from the University of the Philippines Medical Alumni Association. So Franco, welcome to the webinar.
Maraming salamat, Dr. Susie. Magandang hapon po sa inyo lahat. Let me just share my screen.
Franco, mainit ba dyan?
Sa ano lang, yeah, it's getting hotter.
In California, no? You're in California, right? Yeah.
I'm in Bakersfield, so ano yun, disyerto. So mainit sa umaga, malamig sa gabi.
Oh gosh. Okay. All right. So climate change everywhere. So go ahead, Franco. Go ahead.
Just get my pointer here.
It's looking good. Yeah, we can see your slide well.
So magandang hapon sa inyo lahat ulit. So today we will be discussing updates of COVID-19 therapeutics. I have about probably 25 slides, so we should be able to finish this in about 20 minutes. So these are my disclosures. The most important is Gilead. I participated in Remdesivir clinical trials with Gilead, and I participated in sotrovimab monoclonal antibody trials with GSK. So I'll be concentrating on the WHO and NIH guidelines. But before that, let me just provide this with some epidemiological updates on United States, the Philippines, and worldwide. So on the left side are the epidemic curves, and then the right side is the overall activity index in the United States. So here, these are daily new cases, and this one are daily new deaths. As you can see here, this is Alpha, Delta, and the Omicron waves. So the same thing with the death curves, okay? Alpha, Delta, and Omicron waves. So in terms of severity, the worst, in terms of cases, the worst is of course Omicron. In terms of deaths, it's actually Alpha that's the worst. Omicron was actually slightly worse than Delta. And why is that? Because we know Omicron is less severe than other variants, right? The reason is because most of the variants, actually all the variants, only infected up to 10% of the world population, 10%. Omicron, on the other hand, will infect 60 to 80% of the world population, 60 to 80% of the population. So yes, it's less severe, but it's a lot more infections. Now, as you can see here, this is the overall activity index in the United States. So it's been increasing, it's becoming more normal with time. So right now, at least here in California, we don't have social distancing. There's no mask mandates, nothing. Of course, we just use a mask in the hospitals and in transportation. But even in airlines, they already took out the mask mandates. So, but despite this increasing overall activity index, the deaths is the lowest, is at its lowest since the beginning of the epidemic. Now, here, as you can see here, it looks like there's an increase in, the cases are increasing again, but I'm not too worried about this, and I'll explain it later. So this one are the USA variants. So last year, initially, of course, it was Alpha, and then it was replaced by Delta. And now this year, it started with the Omicron. This is the original Omicron. And then it was replaced by a sub-variant. It's still Omicron, but a sub-variant, BA2. And then this sub-variant is replaced by an offshoot of the sub-variant. It's BA2.12.1. Okay, so this is actually incredible because Omicron is behaving like measles, which is the most infectious agent ever. The sub-variants are actually even more transmissible than Omicron. And the offshoot of the sub-variant is even more transmissible than BA2. But there's good news though, because before last year, the evolution of the mutations is radial. It's almost like random. But now the evolution of the mutations is stepwise. Okay, so you have Omicron, you have a subvariant, and you have an offshoot of the subvariant. So it's stepwise. So it means it's becoming more predictable. And if it's predictable, then you can make more effective vaccines, especially if COVID becomes seasonal or annual, just like influenza. So you want it predictable. Now, this is just the estimated excess mortality from 20 to 21. This was published in Lancet just this year, and it's just showing you what is the estimated excess deaths as of the end of 2021, and it's about 18 million. Now, remember, the reported number of cases, reported number of deaths right now is 6 million. So it's 3 times higher. The estimated excess deaths is 3 times higher than the reported deaths. For the Philippines, the reported number of cases right now is 60,000, but the estimated excess deaths is 184,000. Probably by now, it's almost 200,000. It's 3 to 4 times higher than the reported deaths. This one is the cumulative infections. So the other one are deaths. This one is the cumulative infections through November 14, 2021. And as you can see here, about 4 billion of the worldwide population is already infected. That's about 44% of the world population. And the Philippines, it's 60 million. the reported number of infections worldwide is 500 million. Philippines is only 6 million. So it's almost 10 to 20 times higher than the reported infections. Now, imagine, so this is just Delta, okay? This is just all the Omicron, all the variants up to Delta. Imagine if you add Omicron, which will infect 60 to 80% of the world population. So, and then you add the people who are already vaccinated. Almost at least 60% are fully vaccinated in the world. United States is probably 2/3 are fully vaccinated. Philippines is 2/3. So if you add all of that, at least 90 to 95% of the world population will have at least some immunity against COVID. We are not immunologically naive anymore against COVID. Not immunologically naive. So it means, and also at least half will have hybrid immunity, meaning vaccination plus infection or infection plus vaccination or reinfection. So this combination of factors will prevent another major wave of deaths. It will prevent it. So that's why I'm not too concerned, because we're not immunologically naive anymore. At least 90-95% has some immunity against COVID-19. Now, of course, the other strategy to prevent deaths is treatment itself. Okay, so now we have more effective antivirals and monoclonal antibodies for patients with non-severe COVID. So if you have non-severe COVID, this is WHO guidelines, okay? The preferred drug is NIRMATRELVIR and ritonavir, which is Paxlovid, okay? The alternative antivirals is MOLNUPIRAVIR and REMDESIVIR, okay? These are alternative antivirals. Then you have the monoclonal antibodies, sotrovimab, casirivimab, and indevimab combination. Now, the problem with the monoclonal antibodies is they are variant specific. So for example, casirivimab, indevimab combination will not work for Omicron BA1. Sotrovimab will not work against BA2 variant, BA2 subvariant of the Omicron. So that's the problem with monoclonal antibodies. It's very effective, but variant specific. But the antivirals are not variant specific. It will work for any variant, and we'll discuss that later. Now, for severe and critical, we still have these immunomodulators. You have corticosteroids, interleukin-6 receptor blockers like tocilizumab and baricitinib. The problem, though, is in terms of efficacy, they're not very impressive, and we'll talk about that later. Now, how the corticosteroids, remember, are not recommended if the patient has non-severe infection. If baricitinib or tocilizumab are not available, then you can use ruxolitinib and tofacitinib. But this is not really available in the United States. I'm not even sure if this is available in the Philippines. Ivermectin is not recommended except in the context of clinical trial. There's like 2 ongoing large clinical trials right now for ivermectin, but there's already about 4 clinical trials that came out. Convalescent plasma is not recommended anymore. Theoretically, convalescent plasma will work if it's high titer and it's from the same variant, okay? If it's from the same variant, so, but it's difficult to do. Of course, hydroxychloroquine and lopinavir, ritonavir are not recommended. Now, these are the inpatient treatment options now, according to the NIH. So that was WHO. This is NIH in the United States. This is the one we use in the United States. So for hospitalized, but does not require supplemental oxygen, we don't use dexamethasone. We already mentioned this. If they have high risk of disease progression, you can use remdesivir. For anticoagulation, we use a prophylactic dose of heparin, okay? For patients who are hospitalized requiring supplemental oxygen, we usually use dexamethasone plus remdesivir. And we use a therapeutic dose of heparin now, okay? Before it was prophylactic dose. For hospitalized requiring high flow oxygen, okay? Usually 10 liters per minute. The same thing, dexamethasone plus remdesivir, but we add baricitinib or tocilizumab, okay? Prophylactic dose of heparin, not therapeutic, but prophylactic. We only use this for patients requiring supplemental oxygen that's not high flow. Okay, so hospitalized patients requiring mechanical ventilation, usually they'll be on dexamethasone and tocilizumab. Okay, if it's not available, tocilizumab, you have sarilumab. I'm not sure if this is available in the Philippines. And the coagulation is prophylactic. So if the patient was on therapeutic dose before, you have to switch to prophylactic if they're on mechanical ventilation, because it increases the risk of bleeding when they're on mechanical ventilation. Now, the problem though with immunomodulators and remdesivir is their efficacy is not impressive. 17% for dexamethasone, tocilizumab 11%, and a little bit better, 38% for baricitinib. Now remember, dexamethasone has no benefit when not on oxygen. Tocilizumab is used along with steroids early in the course. Baricitinib has less benefit when on ventilation. Okay, that's why if it's available, I like tocilizumab better than baricitinib. But baricitinib is oral. It's oral medication. Remdesivir has no benefit when on ventilation. Now, remember, WHO still does not recommend remdesivir for severe COVID. For non-severe, yes, okay, it's an alternative, but for severe, it's still not recommended. However, this is the updated meta-analysis for remdesivir by the WHO Solidarity Trial Consortium that was just published a few days ago in Lancet. As you can see here on the Solidarity Trial, when you combine patients on low flow and high flow oxygen, the decrease in mortality becomes significant. Okay, statistically significant. And if you add all the trials, it still is significant, statistically significant. Okay, the only problem with this is 0.85 means there's only a 15% decrease in mortality. So just like dexamethasone, which is 17%, and tocilizumab 11%. So it's not really impressive. When you have severe infection, it's not really impressive. So we really need a more impressive set of medications. And luckily for outpatient treatment, we have the best medication. So the drug of choice for NIH is Paxlovid and remdesivir. Now, WHO remdesivir is only a alternative because remdesivir, might not be practical because it's intravenous. Paxlovid is oral. If these two are not available, you can use molnupiravir and bebtelovimab. So this is a new monoclonal antibody. Okay. Now remember, if the patient is discharged from the hospital and they don't need supplemental oxygen, we stop all of this. Okay. Even if they're on remdesivir, usually we give it 5 days. If they're on the 3rd day, we stop it. Dexamethasone, usually give it 10 days. If it's on the 5th day, we can stop it. Baricitinib, usually 14 days, we'll stop it when they're discharged. Now, if they're discharged though, and they still need supplemental oxygen, we continue the dexamethasone, 6 milligrams per day for the whole duration, 10 days. Okay. Now, this is an outpatient clinical decision aid from the Department of Health and Human Services in the United States. And so we start with this. So if the patient is not hospitalized, not requiring oxygen, or not requiring an increase in baseline home oxygen, if they have COPD, their oxygen, if they don't require an increase in baseline home oxygen, and their symptom onset is within 5 to 7 days. Okay, 5 to 7 days. This is better than influenza. Influenza should be within 48 hours. Here it's within 5 to 7 days. Then you can use Paxlovid. Okay, if it's within 5 days of symptom. For remdesivir, it's within 7 days. Okay, it's a little bit longer. So Paxlovid, you cannot give it if the patient has severe renal impairment, meaning less than 30 ml per minute. Or if they have severe hepatic impairment, it's not recommended. Severe hepatic impairment, usually they have ascites or hepatic encephalopathy. So the dose is 300 milligrams. It comes in 150 milligram tablets. So 2 tablets, 300 milligrams with 100 milligrams of ritonavir for twice daily for 5 days. So that's 3, 6 times 5. That's 30 tablets all in all. Okay. Remdesivir is, less practical because it's IV. You have to give it for 3 days, 200 milligrams loading dose, then 100 milligrams daily for 2 days. If these two are not available, then you can use molnupiravir or the new monoclonal antibody bebtelovimab. Okay, within 17 days. Sorry, within 7 days of onset for the monoclonal antibody, within 5 days for molnupiravir. Now, remember, these are only for patients at high risk of progression. Okay, mild to moderate at high risk of progression, and these are the criteria for high risk: older age, BMI of more than 25, so obesity, chronic kidney disease, diabetes, and so forth. Okay, so they should be high risk for progression. If they're immunocompetent, less than 50 years old, no concomitant comorbidities, that you cannot. This is not indicated. Okay. Now, you have to be careful. Paxlovid is a very Paxlovid is a very efficacious drug, but you have to be careful because we have to use ritonavir, which has multiple drug-drug interactions. Ritonavir has interactions with about more than 100 drugs. Okay, interactions. So, for example, there's about 30 drugs where you have to adjust the dose and you have to monitor for adverse events. So, for example, I'll give you an example: sildenafil, Viagra. Okay, so if the patient is taking Viagra, you have to decrease of the dose of Viagra. Otherwise you'll know what happened. Disclosure is not based on experience. Another 30 drugs where you have to temporarily withhold the concomitant medication. Okay. Now remember, we're only giving 5 days of Paxlovid, so you can stop this drug. So for example, statins like atorvastatin, lovastatin, simvastatin, rosuvastatin, you can stop it. Okay, it's only 5 days. Okay. Now, these are the most important though. These are the drugs where you have to prescribe an alternative COVID-19 therapy, or if you cannot replace the medication. So I'll give you an example: anticonvulsants, carbamazepine, phenytoin, phenobarbital. Okay. If you cannot change this to, for example, another anticonvulsant like Keppra, then you cannot use Paxlovid. Another example, anti-TB drugs, rifampin and rifapentin. If you cannot change it to rifabutin, then you cannot use Paxlovid. Okay, so it's don't be scared to give the medication though. Okay, so you just have to be you just have to look at the drug-drug interactions. Hopefully, you have like electronic medical records where we can check the drug-drug interactions easily. Now, these are the monoclonal antibody efficacy. So as you can see here, it's pretty impressive, 70 to 85%. There's for bebtelovimab, there's only a phase 2 trial. We don't have a phase 3 trial yet. The problem is they're variant specific monoclonal antibodies. So let me give you an example. So for alpha, all the monoclonal antibodies will work. Okay, it's fine. But for beta and gamma, the etesimimab-bamlanivab combination will not work. Okay. For delta, most of them will work. Okay. But for Omicron, only cetromimab will work. Only cetromimab and this combination. Okay, which is tixagevimab and cilgagabimab. Unfortunately, these two drugs are not used for therapeutics. This is used for pre-exposure prophylaxis. So if you have a patient who's immunocompromised and the vaccine didn't work, you can use this pre-exposure. Okay, pre-exposure prophylaxis. You cannot use it for therapeutics. Now, how about this is remdesivir? Okay, remdesivir. This is molnupiravir, and this is Paxlovid. It doesn't matter. It still works for any variant. So that's the advantage of antivirals. And of course, you can see it. There's a slight increase, with different variants, but it's only a slight increase. Now, this is for Omicron BA2. This is a subvariant, Omicron subvariant. As you can see here, sotrovimab doesn't work. Only this combination would work. The two, tixagevimab and silgavimab. The problem is you can use this for, therapeutic purpose. You can only use it for pre-exposure prophylaxis. The antivirals are still fine, no problems, okay? And that's the reason why we have to use this new monoclonal antibody for the BA2 variant, bemtelovimab. Unfortunately, we don't have phase 3 trial. It's only based on the reduction of viral load at 5 days versus placebo. Okay, now, these are the oral medication efficacy. Okay, as you can see for molnupiravir, it's not very impressive, 30%. Okay, it's 800 milligrams BID for 5 days within 5 days of onset. It comes in 200 milligram tablets. So it's 4 tablets twice a day. That's 8 times 5. That's 40 tablets all in all. Okay, Paxlovid, 89% efficacy. 89. The chance of reduction in hospitalization or death at 28 days. This is for high risk. It's almost 90%. That's very impressive. Not only that, if you look at the deaths, 12 in placebo, 0 in for Paxlovid. Very effective. Remdesivir is effective too, 87%, although there's less deaths in that study. The problem is, it's intravenous. You have to give it intravenously for 3 days. Okay, we already mentioned all this dosing before. Now, this is just the life cycle and the drug targets. All the 3 antivirals that I mentioned works in this area. It decreases replication. Molnupiravir is a polymerase inhibitor. Paxlovid is a protease inhibitor, just like the HIV, Hep C drugs that we use. And remdesivir is a nucleoside analog that prevents replication. So these are other medications that we can use, that are being tested for COVID-19. These are not direct antivirals. These are more of immunomodulators, but they're much cheaper than the antivirals. So 2 large trials just came out, and it was one for fluvoxamine, which is published in Lancet, and the other one was for ivermectin, published in New England Journal of Medicine. This is part of the Together trial. So they've been checking these 2 medications. I think it's based on South Africa and Brazil. So for fluvoxamine, it's not too impressive, 32% decrease in hospitalization. Okay, but it's comparable to molnupiravir, but it's still not. It's the recommendation. NIH is neither for nor against. They're waiting for more data, but they're applying for emergency use for fluvoxamine. Ivermectin, the largest trial just came out. Is the Together trial. That's more than 1,200 patients. And the result, 10% decrease in hospitalization or death, but it's not statistically significant. There are 3 other trials that came out, large trials, more than 200 patients each. One was published in JAMA. All 3 did not show any benefit. There's 2 other trials that showed benefit, but one was withdrawn because of possible fraudulent data. So there's only one trial, 200 patients each, that showed a benefit. Only one. All the 3 others, and this is the biggest one, 1,200 patients, showed no benefit. There's 2 ongoing trials for ivermectin that are large. One is under NIH, and the other one is, I think, University of Michigan. So we're waiting for that, but I doubt that it will change the overall conclusions for ivermectin. Inhaled medications, these are inhalers, steroid inhalers, budesonide and cyclosinide. I'm not sure if this is available in the Philippines. 32% comparable to molnupiravir, 800 micrograms BID for 14 days within 14 days of onset. But it's still not recommended by NIH. It's neither for nor against. Okay, cyclosinide has a better. It looks like it's impressive. The problem is this is a secondary endpoint. This is not the main endpoint. So, so we cannot really trust this number of 92%. But these 2 at least in practice here in the United States, they use at least budesonide in patients or in the emergency room or urgent care. But remember, this is not recommended by NIH. It's just neither for nor against. And that should be it. Dr. Villalobos will be the next speaker. So I think he'll be concentrating more on the inpatient options. Thank you.
Thank you so much, Franco. Dr. Felizarta, I'm going to watch this again tonight. Really very, 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 very good presentation, very detailed, giving us all of the evidence that we need. And I would say the insight on how important it is to understand these drugs. So thank you so much for your time and for that excellent presentation. And I can always see that you prepare so much for the Stop COVID Deaths webinar. So thank you on behalf of our team. Okay, so Raymond, let's go.
Thank you, Dr. Susie. And thank you for sharing those updates, Dr. Felizarta. We hope to get you in the Q&A so that you'll be able to answer a few of the questions that have already been posed. Our next speaker naman po is an expert po in the Division of Pulmonary Medicine at the Philippine General Hospital. You've already seen him in one of our previous webinars. I think it was a virtual grand rounds, and we're very happy to have him again. He's Dr. Ralph Elvi Villalobos. Dr. Ralph?
Hi, good afternoon po sa lahat. Thank you, Dr. Raymond, Dr. Susie, and to organizers. Actually, Dr. Felizarta already discussed most of the management of COVID. So now I will actually focus on the local management of COVID in the Philippines, so how we did it locally. And I think, no, it's not to really to give praises, but for some reason, we have been actually successful in the management of COVID-19, lalo na in this current Omicron or the recent Omicron surge. So my sources here would be the local guidelines. No? So it will be the Philippine COVID-19 living recommendations it's a joint venture by the DOH, University of the Philippines, and all the medical societies that we have. And of course, the WHO. So the living recommendations of the Philippines were updated actually last January. So last January 2022. So as of last week, actually this week, so we are lucky enough and we're keeping our fingers crossed that it will stay this way, that the Philippines actually would be the flat side of the curve. So we had our share of the Omicron variant and the surge last January, February, and we were really actually very, very had a hard time during the time. Okay, so just a few backgrounder on what the Omicron is and how it differed from the usual or the previous COVID surges. We know that for a fact, Omicron targets the lungs less, and we saw actually a lot less cases in the hospital. So it's maybe because the Omicron was really less severe than the previous variants, but maybe later on I'll talk about what we did on, and we focused much on the outpatient management of COVID, the Omicron, and that's why we really didn't have to deal with a lot of critical and very, very severe cases in the Philippine General Hospital. So we were actually quite surprised that it happened. Now, we had a few cases of patients admitted here in the Philippine General Hospital, not as much as we had expected it during the Delta surge and the Alpha surge. So maybe one of the reasons also is because of this. Now, we were actually lucky enough to have been vaccinated. Some of us were already had our boosters during the Omicron surge, and they actually had seen that in this study, it was published, I think, in the Lancet, that it's actually less severe if we had the vaccinations during the Omicron surge. So I'll focus here on the outpatient management of COVID and what we did in the Philippine General Hospital in the local setting that actually made an impact on how we did the management. So it's a disclaimer that I know that Omicron can still produce severe disease, but we were surprised that due to the sheer number and the volume of cases and the vaccination status of the population, we saw a lot of mild and moderate COVID-19 who didn't need hospitalization. So just a disclaimer, I had my share of the Omicron variant. So actually, I was scared, but actually I was not admitted. And a lot of my friends, a lot of frontliners here in the Philippine General Hospital had the Omicron, but they were not admitted. And thankfully, this was because of a strong outpatient and home-based clinical management during this time. So of course, we should advise our patients that these are the more common symptoms of the Omicron or the COVID circulating during this time. So it's still the fever, chills, the cough, and the shortness of breath, fatigue. But less and less of us, of the patients, had shortness of breath or difficulty breathing. But we should also advise our patients that to seek consult or to go to the nearest hospital if they have this trouble breathing, persistent pain or pressure in the chest, confusion, or if you are already cyanotic or had a cyanotic nail beds, so it's really a warning sign. So these are the risk factors that we should advise our patients. No, so I think Dr. Felizarta had already mentioned this. No, so not all patients actually who had COVID, we advise to take the Paxlovid or the Molnupiravir or what was available during this time. We should always take into consideration that these are the risk factors or some of the risk factors that are associated with severe disease. I think we had during this time we had supply issues then of Molnupiravir or Paxlovid during the last surge, and we have to be judicious of who to give these medications. No? So these are just the patients who are at risk or high risk for developing severe and critical COVID-19. So yeah, this is what we did. We identified the high-risk individuals who had COVID-19 who might benefit from the targeted antiviral therapy, as what Dr. Felizarta has already mentioned. And we had options for partnering with telemedicine or institution have facilities for telemedicine. This is very strong in our institution and in the locality, and I think the DOH has very strong information dissemination regarding this matter. So this is an example of how we did it. So we have in the PGH we have our Telegabay, so it's a hotline for the patients who cannot come to the hospital, and this I think helped really a lot in the patients who our ERs were not actually really, the pila in the hospitals were not very long, unlike in the Delta surge, nagkakaubusan talaga ng oxygen during the time. But in this Omicron, we thankfully did not have to deal with that very bad situation. And again, one of the issues then is the testing. So not during this time, ang dami-daming nagkakasakit, so not everyone has access to the testing, the RT-PCR. And the antigen testing was the primary testing method of choice during the time. And there was even one time that we accepted symptoms plus antigen testing positive as a diagnosis already of the COVID. No? And even with that, the positive antigen testing, and we have the risk factor, we can actually prescribe the antiviral medications as mentioned by Dr. Felizarta. So this is just a timeline of how or when the antigen testing would be positive. So it's actually here at the 3rd day to the 7th day, and where the PCR would test actually positive for a longer period of time. Okay, so I had to emphasize this, that it's really the supportive management and adjunctive management for COVID that was really a lot of time, that a lot of medications were on the supportive and adjunctive management of COVID. So there were a lot to ask about ivermectin, melatonin, stim inhalation, or the SOOB or the TOOB, but we really had to deal with them and to actually educate them that it's really not effective. Okay, and we had a home care program for those high-risk individuals who were on oxygen or who cannot go to the hospitals, or the hospitals in their locality were full. So we had a home care program that actually was a partnership between providers and the hospitals and the universities. So it's really more of focus on intravenous medications and low-flow oxygen. So we had, as Dr. Felizarta has mentioned, we had a lot of patients who had remdesivir at home. So these were administered by nurses who were on home visits, and these are the patients also on oxygen during this time. So this is from the local guidelines during the Omicron surge, when the Molnupiravir was actually the only medication available to us here. So yes, our local guidelines suggested the use of Molnupiravir for those with mild to moderate COVID who are at risk, no, at risk for progressing into the more severe to the critical COVID. So, yun, again, I have to emphasize that it's not for everybody. A lot of patients, no, who are panicky, even they have no risk factors, no, contacted us, no. Doc, gagamit ba kami ng molnupiravir? We have molnupiravir here, but they are healthy, not immunocompromised. They have no other conditions. So we should advise them to be judicious actually with the use of the antivirals that are on hand, because again, we have limited supplies here in the Philippines. Okay, and then again, if in the unfortunate situation that the patient had severe COVID, so we should actually arrange for timely hospital admission or transfer and ICU vacancy, and government partnership is very, very strong in this matter. So this is what we did in the Philippine General Hospital. We have the command center, so we can actually arrange for the transfers of the patients, no, who were severe COVID. So we can arrange in PGH if merong vacancy, or in other hospitals if wala na talaga vacancy in PGH. Okay, so now I'll walk you through severe and critical COVID management locally. So here, I'll focus now on how we did it in the inpatient setting. This is just a short presentation. So just the difference between mild COVID, where the virus is eliminated. So there's actually little or very, very little immune response or catastrophic immune response that's happening. Whereas the severe COVID, no, so there's really uncontrolled inflammation here. That's really most of the thing that's happening in the alveolar, in the lungs. It's really the inflammation that we have to deal with. It's not actually the viral load there, but it's actually the inflammation that we have to deal with. That's why one of the targets for severe and critical COVID management would be the modulation of the immune system. So here we have a picture of the alveoli that's really flooded with inflammation. So we have the neutrophils, the lymphocytes, and all that debris. And then we have also some patients who have clots, no? So that's why we give anticoagulations for these patients. So this is just a timeline of the COVID time course, no? So we have the initial viral response phase, and some patients do not progress to the more severe phase, though they have already cleared the virus here in stage 1 only. But some patients, and we have the risk factors for that, and we have identified risk factors for that, who progress to the inflammatory response phase. And this is the phase wherein we have to deal with in the hospital setting, no? So this is actually here the corticosteroids, the IL-6 inhibitors, and the other immunomodulators that we have in our armamentarium. So in the Philippine General Hospital, we are very, very lucky enough to have developed our own local guidelines, and I think these guidelines were cascaded to the other institutions, and some have adopted and were benefited from this guideline. So I'm not sure if this has been updated, but this is the latest version that we have. But we actually triage our patient first if is this a mild, moderate, severe, or critical COVID. No? So for the mild COVID treatment, again, this is not really managed in the hospital setting, and this is actually managed in the home. So for the Omicron, these are the ones who will benefit from the outpatient antivirals that were available during the time if they have risk factors. And then for the moderate, also ito rin yung mga patients who are in the hospital but are not auto requiring. But at this point, we actually give enoxaparin. And tingnan natin here on the right side, we are a research university, but we have a lot of research clinical trials for COVID. So our priority this time was to enroll them in the clinical trials. But for the more severe COVID and more severe and critical COVID-19, we have standard of care during this time, which is dexamethasone, enoxaparin, and remdesivir. No? So dexamethasone is, I think this is the first medication that was actually proven to be beneficial in terms of mortality. The recovery trial was the first trial that proved that. Okay, and if the patient is still willing to be enrolled in the clinical trial, so we can actually enroll the patient in a clinical trial on top of the standard of care that is being given. Okay, for the critical COVID demand, that's still the same standard of care, dexamethasone and enoxaparin, but we have to be careful because in this critical COVID, lalo na if the patient is intubated already, remdesivir, the benefit of remdesivir is not that apparent. No? So Here, if the patient is very critical or progressing, rapidly progressing, we can actually give tocilizumab or baricitinib, as was mentioned by Dr. Felizarta. Okay, so now I will walk you through the evidence for remdesivir. So early trials, the ACT-1 trial results, no, so there was superior, the results said that it was superior to placebo in shortening the time to recovery, but there was no benefit in mortality. Actually, you see the greatest benefit when given early in the time course of COVID and severe illness, no, rather than those intubated or mechanically ventilated already. So remdesivir would be beneficial for those who are on oxygen lang, but not yet on mechanical ventilation or on high flow. And this is the actual living recommendation guidelines for remdesivir. So it is suggested, it is not suggested pala in the patients who do not have oxygen supplementation. So yung mga room air natin, the patients, even if they have that mababa ang oxygen 94 or mataas ang oxygen pala na 94%, and they do not require oxygen supplementation. So the evidence for remdesivir is not that strong. Okay, and if they require oxygen now, you have to give the standard of care, which is dexamethasone, on top of the remdesivir that you are given. So these are the patients who have the strongest benefit from the remdesivir. But if the patient is already on mechanical ventilation, so there is little benefit if you add remdesivir. So this was presented earlier by Dr. Felizarta. So our hospital was one of the institutions who participated in the WHO Solidarity Trial. So this was published last week. This week, actually, May 2, 2022. So this is a very, very fresh article. And it just validated the results that in the patients with oxygen, but not yet ventilated, we see benefit of remdesivir here. But look at the patients who are already ventilated. No, look at the patients who are already ventilated. You do not actually appreciate the benefit of remdesivir. So the guidelines and the recommendation strongly says that it is the benefit of remdesivir is actually in the oxygen requiring patients, but not those in the non-oxygen requiring patients, and not for the intubated or mechanically ventilated patients. Okay, now let's go to the anti-inflammatories and immunomodulators. As I mentioned, COVID is really an inflammatory disease, and most of the effects are from inflammation. So we have to deal with the inflammation here. So one of the early trials actually was this, the recovery trial, no? So this is dexamethasone, and actually this is the one trial that has proven that superiority of dexamethasone over placebo or usual standard of care in terms of mortality. That's why dexamethasone is in the backbone of all the patients who have severe oxygen requiring to critical COVID-19. Okay, so this is from our local guidelines. Should systemic corticosteroids be used in patients with COVID-19 infection? Yes, this is the strongest recommendation that dexamethasone should be given in patients with COVID-19 who require supplemental oxygen even on mechanical ventilation. So this is the answer actually to the quiz earlier. So the answer is systemic corticosteroids. No? So for those patients who do not require oxygen, yung nasa bahay lang, a lot of us ask, Doc, kailangan ba namin ng oxygen? Na-COVID ako. Kailangan ba namin ng dexamethasone? The answer there is no. If you do not require oxygen, dexamethasone is not beneficial. Okay, tocilizumab, again, for the recovery trial here, there is no evidence that tocilizumab have any effect on mechanically ventilated patients. So we give tocilizumab actually for those who have oxygen support, who are rapidly progressing to high flow or increasing supplemental oxygen level. And actually the benefit is more if we give this in these patients rather than if we give this to the patients who are already on mechanical ventilation. So this is from our guidelines. So we recommend the addition of tocilizumab to systemic steroids in patients showing rapid progressive respiratory deterioration. And it recommends, of course, you should not give tocilizumab in patients who are admitted who do not require oxygen supplementation. As mentioned by Dr. Felizarta, these are the other therapies that are not proven to work. So ivermectin, hemoperfusion, and the antifibrotics for COVID-19. So in summary, that was the end of my lecture. So we have actually to establish the recommendation is to have a strong outpatient management of COVID. And it was actually the one that I think we were very, very effective at during the Omicron surge, because it became the cornerstone of the management of COVID-19. And it's not, to discount the fact that Omicron can still produce severe and critical COVID-19. So we have to still be watching out. It doesn't mean that if you have COVID, Omicron yan, or that it's probably Omicron, you cannot progress to the severe and critical COVID. So we have to still be careful about. Vaccination has decreased the incidence of severe and critical COVID. And as mentioned earlier, the same antivirals and immune modulators work for all the cases of severe and critical COVID-19, regardless of the variant. So it's really the evidence here for the Paxlovid, for Remdesivir, and for dexamethasone actually are strong as long as you use it in the appropriate clinical context. It's not for everybody, but there are just specific patients who have can derive benefit for these antivirals and immune modulators. So I think that's it. So thank you very much again for listening.
Okay, thank you very much. That's Dr. Ralph Villalobos, infectious disease specialist, who we always like. Uy, teka,
Pulmonologist, Dr. Susie.
Ay, pulmo nga pala si Ralph, sorry. Pulmo si Ralph, correct. Oo, sorry Ralph. Pulmonologist, and thank you so much. I think you can see the audience is appreciating your presentation with emoticons. Sige, Raymond, go ahead. Over to you.
Thank you, Dr. Susie and Dr. Ralph. We'll be requesting both Dr. Felizarta and Dr. Villalobos to switch on your videos. And as you are doing that, we'll just take a very, very quick break for our special
cute, Raymond. Tinan daming mga emoticons.
mga reactions.
Ang cute. Oo. Thank you so much, our audience. No? Sarap.
Maraming salamat.
Sarap makita yan eh. Oo, nakakatuwa. Oo, sige, okay.
Opo. TVUP, can we have our special public service announcement today?
Maaari na bang magpabakuna ang mga batang 5 hanggang 11 taong gulang?
Oo, nagsimula ito noong Pebrero.
Nagpapakuna na ba kayo?
Oo, nagpapakuna na kami.
Kaya mga bata, magpapakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of our webinar team to push for pediatric vaccination for children aged 5 to 18 years old. We hope you'll be able to share this message to everyone po. No? Please contact us, especially if you want to have your own copy of that clip, and we'll be happy to send it your way. Dr. Susie?
Oo, ang cute naman. Raymond, ang galing ng TVUP, no? Kasi ko parang very creative. We just like to appreciate really TVUP for all the creative materials that make our webinar more interesting for all of you, no? Ayun, marami na naman tayong mga emoticons. Okay, so we've got Dr. Franco and we've got Dr. Ralph here. And we have a couple of questions in the Q&A box. But let me start off our questions by asking our two doctors. So I think Dr. Franco focused on the outpatient care and Dr. Ralph focused on the inpatient care. So let me ask you, you're both in practice, you're both very well-established clinicians. Do you think these medicines are sufficient, or we should, we could be expecting more efficient drugs coming our way? And if you know of any, would you like to share some more information? Kasi may mga pros and cons pa rin, di ba? Sige, go ahead. Maybe we'll start with Franco.
Well, Paxlovid is, is pretty, we're talking about 90% decrease in hospitalization. So I think there's several other antivirals in development, but I mean, I think it's sufficient, with Paxlovid. The only thing with Paxlovid is it's still emergency use. If it's fully approved, that would be better. Because remember, if there's let's say there's influenza, let's say there's an influenza season, right? And they call you for influenza. We don't even check the patient for influenza. We just treat them with medication empirically. So, if it's fully approved, I think that's the best way to give the medication is to just give it empirically. Only if if the FDA approved. Right now, it's emergency use authorization. You need to have a positive test. The problem is sometimes there's a lot of false negative tests for the antigen test, and even the PCR. By the time they check it, it's negative, but the patient actually had COVID. So that's one utility for empiric treatment that would work for that. But right now, it has to be a positive test and high risk progression. But I'm hoping there's more trials for patients with who are low risk and see if there's actually a benefit even in patients who are low risk.
So more studies are needed. What's the good window for giving Paxlovid in your experience, Franco?
Well, initially they thought it was just the best would be within 3 days. So within 5 days, the best. So within 5 days, yeah. Most of them, Molnupiravir is also within 5 days. Remdesivir, the study showed within 7 days. But right now, within 5 days is the best. And especially for Omicron is so fast. I mean, the incubation period is only 3 days. So you have to, that's why, I'm hoping in the future, we can use it empirically, because if you have to test it, that takes another day or two. And then if it's negative, you have to retest again with a PCR. So, because it's just so fast. But that's why it's very hard to prevent infection with vaccine. If you have a respiratory virus with an incubation period of 3 days, it's very hard to prevent infection. But vaccine prevents severe infection. Okay, so it's still important to have the vaccine. So even if we have all these breakthroughs and reinfections, I'm pretty sure that the reason why we have less deaths with Omicron is because of vaccination. If without the vaccination, it would have been worse. We're talking about 60-80% of the whole world population being infected. Imagine if it was alpha infecting 60 to 80% of the population at that time that we don't have any vaccine. That would have been even worse. Right now it's like 20 to 25 million already killed by COVID. It would have been worse without a vaccine. I'm pretty sure it would have been like 50 million, maybe 50 to 100 million without the vaccine.
Yeah, I mean, I think when we're looking at treatment, also the efficiency of testing is in play, no? As you said, right now, because under emergency use, you have to have a positive COVID test, and if you have high index of suspicion but it's negative, you still need to do a PCR. So that's right, no delay. So I think there's still some. I guess a lot of room for improving on the therapeutics of COVID-19. Ralph, how about you? Are you fairly confident about the drugs that you have as tools to manage your patients in the hospital?
Yeah. So as mentioned kanina, Dr. Susino, so actually in the inpatient, lalo na in the severe and critical COVID, we still really need a lot of studies now. So as you saw, the efficacy rates of tocilizumab and remdesivir, they are actually effective with a little efficacy rate in the severe, not critical COVID. But for the critical COVID, it's actually the area where we really need more studies that are more robust, who have evidence, and the benefit would be seen. So it's fortunately for now, it's still the corticosteroids for the critical COVID, but for the others, the benefit is still in the gray area. So we really cannot say that it's effective. No? So unlike in the outpatient management, it's the benefit is there, but for the inpatient management, not so much. So we really need more studies for these kinds of patients.
Yeah, and I think the effort also of making sure that patients don't become severe, no? So the early diagnosis,
Yes.
immediate treatment, no, and really the awareness of all our frontline workers that there is something that can be done really in the early stages, no. So I think there's there will be still a lot that we'll have to wait for in terms of the development of the therapeutics in severe cases of COVID. Okay, so thank you very much to both of you. Raymond, let's harvest some of our questions from the audience, and we're encouraging all of you to to ask questions. I'm sure you have questions about I'm sure you have questions about treatment. So
Yeah.
please go ahead, Raymond.
I'll be choosing the upvoted ones, Dr. Susie. And this one,
Okay, go ahead.
just because Dr. Ralph mentioned steroids, this one comes from Dr. Ambrose Alvaro, who is one of our regulars. He's asking, can we use some other steroids such as prednisone, hydrocortisone for treatment?
Yes, definitely, doc. You can use other steroids, hydrocortisone or prednisone, but in the trials, kasi it's the dexamethasone that was really actually used for most of the patients, lalo in the recovery trial. So it's dexamethasone 6 milligrams. But we have alternatives like hydrocortisone 80 milligrams. You can actually use that. Or if it's really not available, you can actually use methylprednisolone or prednisolone. But if you want to derive the benefit as what was the trial speaking, it's dexamethasone that is really recommended. But you can use the alternative steroids.
Thank you,
Right.
Dr. Ralph. Next question po comes in again from one of our regulars, Joseph Tortona. Are there randomized controlled trials on the use of Montelukast levocetirizine on the treatment of pre and post-exposure to COVID-19? If so, what are the results? I'll post that to...
yeah.
Sige, go ahead.
Well, for Montelukast and levocetirizine. So yeah, there's a retrospective study. I think Rutgers University. It's not a large trial, and it's a retrospective trial. So I think the decrease in hospitalization was 30% for the Montelukast and only 10% for placebo. But remember, this is a retrospective trial. So I think they're trying to use this too for long COVID, but I have not heard of any randomized clinical trial for both medications.
Thank you, Dr. Franco. Next question naman po comes in from Dr. Frances Perez. What is the mechanism of action of fluvoxamine against COVID? Is this now being given in the United States or in the Philippines? Would other SSRIs be just as effective?
Well, it's an immunomodulator, the fluvoxamine. Yes, there's actually studies for SSRI, other SSRIs, but those are retrospective studies. This is the only one with a prospective trial is fluvoxamine. There's two of them, a phase 2 and this one is a phase 3. It's a large trial under together. They're actually trying to get an emergency use for fluvoxamine. The problem is you already have this excellent direct antiviral Paxlovid, which has 90% efficacy. So at least here in California, nobody's using fluvoxamine. They're all using either initially molnupiravir, but Paxlovid is the number one drug that we're using. It's really only the preferred oral drug right now by the WHO and NIH. I mean, remdesivir is a preferred drug as an IV for NIH, but it's impractical. It's 3 days of intravenous medications.
Ralph, we do have Paxlovid in PGH, right?
Yes, we have Paxlovid, we have Molnupiravir also. So it's not sold under the Paxlovid brand, but it's the generic. I think the
Right.
manufacturer has granted it to be manufactured by the generic, but it is available. You just have to contact your provider to give the prescription and then the instruction. So it's available.
So is it available in other hospitals
I think
as
so.
well? Or
Yes, I think so.
it is, but it's not in the drugstore kasi it's also
No.
emergency
Yes.
use, no?
Yep.
And then
Because you
what
have to.
is it cost like? Ano yung price? Kasi I remember one of our in the persons on the street,
Yeah.
someone was saying na mahal siya. What is the price like?
It is actually expensive, no, for the 1 day. It's sold in a blister pack. Tama yung kanina sa one street. So it's a blister pack. Each is like a combi pack na you have to take for 5
Ah.
days. So each combi pack that's good for 1 day, 2 times a day, it's 3,000, around that number, 3,000 to 3,500 per day. So you have to take that for 5 days. That's the generic counterpart already of the Paxlovid.
So parang mga 15,000 pesos a day, no? Parang ganyan.
No, for the
whole
entire
course.
course. Yeah.
For the whole course, no? That's still quite prohibitive. But again, that's really cheaper than being hospitalized. And of course, you don't want the side effects of long COVID, no? I take the risk of that. Pero mahal pa rin, ano? Mahal pa rin siya. Hindi pa rin yan within the reach of ordinary people. There's another question here, Raymond, which I found really interesting. Saan na ba yan?
From whom, Dr. Susie?
Teka. Nakita ko kanina. Oh, about supply. I think that's a good question, no? Supply of molnupiravir and remdesivir. What do we know about that, Ralph?
Hi, Doc. So
I remember before, no, at the surge. Ay talagang ano yan, may black market, di ba?
yes,
Merong
yes.
sa Viber, may nagbebenta, merong mga doktor na ano. What are we looking at in terms of supply now? Do we have better stocks?
Yes, actually, Doc, I don't know if this is a bad news or what, but I'll talk about Paxlovid muna. Actually, we have near expiring Paxlovid because the Paxlovid was, the NIRMATRELVIR-RITONAVIR was delivered after the Omicron surge. So there was the demand was actually less, but yun nga, the timing of that is actually oversupply tayo ngayon. And there are less and less patients who are actually availing of that. For molnupiravir, during this time, actually marami pong supply. Again, molnupiravir is, I think the Merck was the innovator, but the generics, we have a lot of generics here, and they are sold actually in pharmacies and in black markets. But supply-wise, all these medications are, I think, for now, they have adequate supply, but we cannot say, hopefully not, in the near future, sana walang surge. But for now, they are adequate supply pa.
Okay, so that's very interesting, no, na malapit na mag-expire. Ibig sabihin, itong mga Paxlovid, kasi kailan lang naman lumabas yung Paxlovid, di ba? Na talagang maikli ang shelf life niya. I mean, we haven't had this drug available for a long time. It's just been a couple of months.
I think 1 year lang yata, the shelf life is maximum of a year because I think it's a new drug. So that's the safe window for the shelf life of the generic Paxlovid.
Yeah, okay. So, Raymond, there was another question here about the warning of the department. Saan ko ba nakita yun? Hindi ko alam kung sa text ko or whatever. The warning of the Department of Health na baka ron magkaroon ng surge after the elections. What was that question about? That was also really interesting. Yeah.
I think it was in the chat, Dr. Susie.
Oo, in the chat, no? Tingnan mo natin yan.
Sige. While you're searching for that, Dr. Susie, this one comes from Joanna Lauganas. What is the science behind remdesivir generally being given only within the 5 days po? That kind. Dr. Franco?
Well, remember, it's the level of it's only the first 1 to 2 weeks that you have a high viral load. Okay, so but actually by the time you diagnose the patient, it's already like 5 to 7 days. So it's probably usually another week with a high viral load. So you just have to give it in a short duration, less than 7 days. If you give it for a longer duration, it will be useless for the next probably next week because the viral load by the time will be already low.
Okay. So it has to
Remember
do with the viral load.
Yeah. The problem is there's a very high viral load in the first phase, and it's able to escape the innate system, and then what happens is later on the innate system overcompensate. But by the time the viral load is already low. So the problem is the overcompensation of the innate system, and then the adaptive immunity is like non-existent. So that's the two main problem for severe COVID. overcompensation of the innate system and low adaptive immunity. So it's not really the best way to prevent this is to decrease the viral load in the first week. Yeah, if you can decrease the viral load in the first week, because you have to help the innate system. If you decrease it, then it will not overcompensate later. So yeah, you only need it for less than a week.
Yeah, okay. I can't find the question, Raymond, but there's a question here from Riza Relova. Any age limitations for Paxlovid and Molnupiravir? What do we know about age, using it in specific age groups?
Well, for molnupiravir, it cannot be given less than 18 years because the problem with molnupiravir is the mechanism of action. It increases the mutations. So it theoretically it can cause mutations. So even in the host. So pregnant women, it's contraindicated pregnant women and in less than 18 years old. But for Paxlovid, though, I don't think they have that restriction.
Okay, so so we found the question, or Cecilia Pulido wrote it again. Good afternoon. The DOH warned of a possible surge in the post-election period that some experts also claimed that the pandemic is going to be in an endemic stage. Ano ang panawagan niyo sa mga pinuno, magiging bagong pinuno at ang ating mga kababayan tungkol sa state ng pandemic? Recommended bang stockpiling? I think it's a good question, right? Yeah, should we be thinking about that? No? Kasi if we're anticipating a surge, then we have to think ahead, right? What do we need if there is a surge? So what are your thoughts on this? Although, just a reminder to everybody, whoever gets elected, sa July pa po yan magte-take over, no? Hindi naman yan pag na-elect ngayon, ay uupo na sila. Matagal pa po yan. Mga June pa yata or July. Ano ba, Raymond, ang date? Biglang election ang pinag-usapan, no? Parang hindi pa no? I think the swearing in is probably in June, no? End of June, early July. Yeah. Okay, so it's still the current administration that will be, if there is a surge, it will still be the current administration. So any thoughts on that, Franco and Ralph? You think we should be stockpiling? And this is a disadvantage in the Philippines. You know, we're importing the drugs, no, unlike in the United States, so it's manufactured in the US, so you don't really have to think about that. But for us, we're importing it, and therefore there's the question about if you order too much and then it expires, it's a problem, right? But if you don't order it ahead of time, problema rin siya. So what are your thoughts on that? Franco, ikaw muna.
Yeah, well, a problema here you have to predict. So we're thinking COVID will become seasonal or annual, and usually and probably coincide with influenza season. Okay, so although there's probably gonna be some interference there's some theory that it might interfere with each other, but still it's probably gonna be, at least in the United States, it's winter time, right? So we have to prepare for winter. In the southern areas, sometimes we get a surge in the summer, like Florida, Texas, we get some small surge. Now in the Philippines, though, I forgot what is your influenza season? Up to what is it, August to October?
Ayan si Ralph. Ralph, kailan bang flu?
Yeah, the rainy season. Rainy season. Yeah, that's why the vaccines arrive April now, and then mag-influenza season ng mga rainy August, October, December.
So yeah, so that's if it coincides with the influenza season, then you probably expect a surge during that time. But I'm not that too concerned about at least infections. It will go up, but in terms of hospitalizations, if the Philippines, if you look at that data I've showed, by November 14, 2021, almost half of the Philippines is already infected. Okay, so imagine with Omicron, it's probably going to be at least 80%. At least one infection. Plus, you have all 66% of Filipinos already fully vaccinated. So if you combine that, at least 95% will have some immunity against COVID. So even if there's a new variant, you still have some immunity against it. So
Right.
that's why flu.
Yeah.
When the flu comes in, it only infects 10% of the population because the rest have some
Yeah.
immunological immunity. So it can only infect so much, or if it infects a lot, at least it prevents severe disease. So I'm not too worried about a major wave with increased deaths. Maybe infections, but not increased deaths.
Yeah, that's something we what should I say, some kind of advantage we've gained over the past year or two, no, year and a half, with exposure and with vaccination. Sana naman hindi na siya hindi na siya surge na katulad nung dati na napupuno yung ospital. Okay, so so one of the things we wanted to do in this third season is to end on time. So we have now made our sort of, we have less guests, we have more time for conversation, and so we want to continue to be on time and really honor your time with us na matapos tayo at the top of the hour. Okay, so right now we're gonna ask our speakers to compose their thoughts about parting words for our frontliners about treatment, and I'm very sure our audience has really appreciated the updates on therapeutics, because as you could see from our persons on the street, hindi alam ng mga tao di ba? Na merong ganun merong treatment. Sige, Raymond, over to you.
Well, before they craft their
Fun
final
quiz
messages,
muna.
Dr. Susie,
Fun
we
quiz
will ask
muna.
each of them the answers to the fun quiz. Can we have the Slido on the? Thank you so much. First question, we'll ask Dr. Franco to answer this. This is something that we want to be done po in terms of having the expert be the one to state from himself or herself the correct answer. For the first question, it reads, Paxlovid contains ritonavir, which has multiple drug interactions, including rifampin, phenytoin, and simvastatin. Is it true or false, Dr. Franco?
Definitely true. I've shown you more than 100 interactions with Paxlovid, so including Viagra.
Yun, okay. But
Nako,
not
funny talaga yan. Alam mo, natawa talaga ako nung sinabi ko sa ako yan. Lalo na yung may disclaimer ka. Okay. Para maganda yatang gawin public service announcement. I'm joking. Yeah,
Second
okay.
question, we have this one for Dr. Ralph. What is considered the standard of care of inpatient management of severe COVID-19? I know we've already mentioned it, but please repeat it, Dr. Ralph.
Yeah, it's still corticosteroids. Actually, that's still the first, and actually up to now, the only evidence that has very, very strong recommendation. And it's actually standard of care for all patients with COVID-19, severe COVID-19. Hemoperfusion and molnupiravir are not considered standard of care for severe COVID.
O yun. Thank you so much. Kasi dito po sa Zoom, if you're able to see it, molnupiravir po ang pinakamataas sa mga sagot. But thank you so much, Dr. Ralph and Dr. Frank.
At saka naman, Raymond, no? Parang I think our purpose really is to walk away from the webinar with two main points that you can remember.
Right.
Kasi ang daming pinag-uusapan, tsaka ako, binabalikan ko yung mga pinanonood ko talaga ulit. Kasi parang, when you watch it the second time, parang, yun nga pala yun, So, we are always on a journey of learning. But those the 2 or 3 questions in the fun quiz are really meant for us to, what should I say, to remember at least 2 things, diba? Kasi ang dami. Sige, go ahead, Raymond. Evaluation naman?
We also have our evaluation. Thank you so much. This is a 5 questionnaire po na evaluation. Remember, wala po kami nilalabas po na separate na evaluation po. Ito na po yun. So we hope you'll be able to enter or input your evaluations po. We are seeing na unti-unti na pong pumapasok ang mga evaluations. Sana po our experts take this time to craft their final messages to our audience. The first statement for the evaluation poll, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And number 5, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing this evaluation poll as we now move on to our final messages. Dr. Susie.
Okay, so let's get our final message first from Ralph. Ralph, what are your parting words for our frontliners?
Yeah, so thank you very much po again for inviting. And the message here is clear. Number one, we still do not have the really proven strong medications for the severe and critical COVID. So our message here is clear. We want to prevent a patient from becoming severe to critical. So we have a lot of proven strategies actually. So one is vaccination. Number two, we have the oral antiviral medications. And of course, number three, we want to distance ourselves if we are immunocompromised or if we have risk factors for the severe COVID-19. So I think that's all my messages.
Thank you very much. That's Ralph Villalobos of the Philippine General Hospital. Let's go to Franco. Franco, please go ahead.
So, yeah, I agree with Dr. Villalobos regarding severe COVID. We don't have very impressive treatment regimens for severe COVID. So it's very important to prevent that stage. And of course, still number one is vaccination plus a booster. And if you're high risk and you're elderly, then you probably need you probably need a second booster. And of course, if after all of this you still get infected, you're high risk, then at least we have a very efficacious medication, Paxlovid. Prevents almost 90% of hospitalization. So, and then we have several alternative medications, not as impressive as Paxlovid. So, yeah, the most important, of course, vaccination, booster, and then if you get infected, at least we have this important antiviral medication. Thank you.
Thank you very much. It's Dr. Franco Felizarta, who's coming to you from the United States. He's also very active at the UP Medical Alumni Association of the US and infectious disease specialist. Thank you so much. Okay, so now we have a synthesis by none other than the Chancellor of the University of the Philippines in Manila, Dr. Carmencita D. Padilla. Menchit, over to you.
Okay, thank you, Dr. Susie. Magandang hapon po sa inyong lahat. As we see the tail end of the Omicron variant and the appearance of new variants, we continue to watch out for developments on the diagnosis and treatment modalities. And also as more mild and moderate COVID cases are seen in the clinics and in the hospital, we review home care as an option to avoid another overload of hospital admission. So today's webinar focuses on the treatments that are hitting the deadlines. And the newest drug in the market is NIRMATRELVIR or Paxlovid, highly recommended by the WHO. Our presenter is Dr. Franco Felizarta, who gave us the updates on COVID-19 therapeutics. He refers to the WHO and US NIH guidelines. He started by sharing the epidemic curves, and Dr. Franco said, yes, the deaths are due to Alpha. Yes, Omicron is less severe, but while most of the variants affect 10% of the world population, the Omicron affects 60%. Now, both Dr. Franco and Dr. Ralph gave very similar views on treatment modalities. So I urge you to watch the replay to go into the details of their views. So allow me to summarize the points that both raised. Number one, Paxlovid is the newest drug in the market. It is highly recommended by WHO. It works on all variants. It is still an emergency use authorization, needing a positive test. The nice thing about Paxlovid is that it's highly recommended because it is an oral medication. Now, both discuss Remdesivir as an efficacious drug, but has to be given by IV. But Dr. Ralph shared that the data of the Solidarity trial, where the Philippines is a participant, and the data show that the very new data shows that Remdesivir has the highest benefit when the patient is on oxygen requirement and not ventilated. So this only shows that we have to continue contributing our data to big international trials so that we can see whether the recommendations will stay the same or will have to be modified. The next discussion was on the monoclonal antibodies, where both said that they're effective but very specific to the variants. And as a matter of fact, Dr. Franco showed a table wherein this particular monoclonal antibody works in this particular variant. So you have to go back and take a look at the table. Both discussed the role of corticosteroid in the standard care among patients. Now, Both Dr. Franco and Dr. Val presented the data on ivermectin. And as Dr. Franco said, it is not accepted except on clinical trial. Likewise, Dr. Franco said that convalescent plasma is only used in the context of clinical trial. Now, what's interesting and maybe good to know for all of our audience is that in the Philippines, we have all the medicines that they have presented in today's presentation, including the Paxlovid, which is carried by another name. Now, Dr. Franco warned us on the use of this medication on high-risk individuals. Again, there's a long table, but just to mention two: older age and obesity will have to be taken into consideration, as well as contraindications like the kidney and the hepatic impairment. One interesting table that you have to go back to, the table on the drug-drug interactions. While many of us in the audience are taking so many other medications, it's not that simple that we take a new drug related to COVID. So we have to take this medication with the guidance of a physician. We were all cautioned to review our meds now and the medications of our patients before we prescribe any of the new drugs that are presented today. Our reactor is Dr. Rolf Villalobos, and he gave the following highlights. I have incorporated his comments in the earlier part of my presentation, but let me give you his sharing with regards to the Philippine General Hospital. Now, Dr. Wolf observed that in PGH, during the Omicron surge, there were less hospital admissions, and probably because of the vaccinations and the boosters of our population. So he focused his presentation, the second part of his presentation was really on the strategies of PGH on the outpatient as well as the home-based clinical management that is highly advocated by the PGH staff. He cited 4 strategies. The first one is identify high-risk individuals who might benefit from targeted antiviral therapy. And the PGH has partnered with telemedicine partners to make sure that they do not have to come to the hospital. The second outpatient strategy was the use of antigen tests during the surge, since there was no ready access to the RT-PCR testing. The third outpatient strategy was treatment under the home care program, which definitely contributed to the non-overloading of PGH during the surge. There was emphasis on the supportive and adjunctive treatment and the use of antivirals on an OPD basis. The fourth outpatient strategy was actually connect. And he said that it is very important that the hospitals and the patients, for that matter, connect through the hospital system to specific referral flows so that they are able to be transferred or admitted at the right time. Now, the next part of, actually both Dr. Franco and Dr. Rolf talked about the clinical course of COVID. But if I may just mention a few points that both talked about, the mild and severe. And I think it's something very important for us to review as health professionals in the audience. Whereas Dr. Franco talked about the NIH and the US NIH and the WHO guidelines, Dr. Rolf talked about the PGH local guidelines, which basically comes up with a triage form from the mild, the moderate, and severe, ensuring that every patient is given the proper treatment and the proper attention as they come forth to the hospital setting. Now, I really urge all of you to watch the replay, because I think, in the interest of time and the interest of our love for knowledge, we have to go back and find out what's new with the new treatments. So indeed, there is already a move. So in summary, there is really a move towards outpatient treatment, whether you're in the US or in the Philippines. There is a different form of treatment for the mild or the severe. Definitely, vaccination has played a very important role in the reduction of the overload in the hospitals. And one thing is clear is that the antivirals do work, and we have to remember that we just have to take them with great care. But today, let me end with the sharing of Dr. Franco. After 2 years, we all know that we know better. As a matter of fact, we know that variants will emerge. But there's something that Dr. Franco said. Since we know better, we know that the evolution of the mutation is stepwise. It is now more predictable. And this means that we can have more effective vaccines. And hopefully, very soon, it becomes seasonal. And what is, if I look at when he said that we are not immunologically naive at this time, because about 90% of us have some form of immunity, either through vaccination, infection, or reinfection. So talagang kailangan tayo magpabakuna o kaya magpa-boost na ngayon. Maraming salamat sa inyong lahat at back to you, Susie and Raymond.
Nako, thank you very much. That's none other than the Chancellor of the University of the Philippines, Manila. Ang galing talaga ni Menchit, no? Wala akong power na ganyan, Raymond. Yung lahat ng detail, she doesn't have time to prepare. She's just listening like you and me. But she can really summarize and remember so many things. So thanks so much, Menchit, for that really excellent synthesis. Okay, so next week, nako, don't miss it. Pag-uusapan natin mga booster. And ito nga, maraming nagtatanong sa akin, sabi, Doc, nagpaano kasi ako nagpa-Sinovac. Pagkatapos nagpa-ano ako, Moderna. Magpapa-booster pa ba ako? O kaya, Doc, nagka-COVID na ako Tapos nagpabakuna ako. Kailangan ko pa ba ng booster? Bakit pa ako magpapa-booster? So we are going to get to the root of boosters. Do you need a booster? What is the age group or what are the indications for a booster? Yan po pag-uusapan natin next time. So be here next Friday and invite all your friends who are interested in booster. We of course have a great lineup of experts for you to answer your questions. So over to you, Raymond.
Thank you, Dr. Susie, and thank you again to our Chancellor for excellent synthesis and closing remarks po. But before we conclude our program, we'd like to point you po to what we lovingly call po our SCD shorts. These are very, very quick and consumable po na mga short videos. You could find them if you go to youtube.com/TVUPPH, and there you'll be able to get snippets of the important information for each of the webinars that we have churned out to date. Also, we will not be here without the very hardworking team behind the Stop COVID Deaths webinar series. Without each and every one of you, will not be able to churn out, again, quality content week in and week out. We'd also like to inform everyone that all Stop COVID Deaths webinars are archived for viewing, lalo na po yung mga gusto pong manood sa playback sa YouTube channel ng TVUP. Again, if you go to youtube.com/TVUPPH, you'll be able to see all 97 webinars. And then after this webinar po, it will be 98 webinars that are archived there. Makita-kita po tayo ulit next week. Advance Mother's Day po. Happy Mother's Day po sa lahat-lahat po. Maraming salamat po sa lahat po ng ina at lahat po ng ginagawa po ninyo. At sana po sa Lunes, vote po with conviction and according to your passion and principles po. We'll see each other next week during our regular Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy. See you online.